Hi, today to talk about myasthenia gravis and Lamber Eaton Syndrome. As always, we start with a case. We have a 25-year-old woman noticed that a week ago her eyelid drooped at night and resolved in the morning. This occurs on two occasions, and yesterday she developed a double vision while looking to the left. There are three main points that you have to identify them immediately. The first one is we have a young woman here, and the second one we have her ptosis, a drop of eyelid happen at night and in the morning, and the timeline here is very important. And then also she developed a double vision while looking to the left, which is diplopia. And these are a very important symptom that points to myasthenia gravis. So one of the very distinguished characteristic of the symptoms of MG is that muscle weakness worsen in increased use and improve with rest. So why I asked you to focusing on the timeline, because this is she find this symptom at night, which after a day use, and we solve in the morning, which means after sleep. So they fully match the characteristic of this column. And then there's ocular weakness, which diplopia and blurred visions. And please be reminded that the ocular weakness is always commonly the first symptoms to show up to find in an MG patients. And others, we have postural muscle weakness, or we have proximal muscle weakness, or we have respiratory muscle weakness. And other stuff you can try to understand for you for not to memorize is the proximal muscle weakness which is the proximal muscle is those muscles near the trunk, right? Let's say, for example, your thigh. So this is why the patient is so difficult to stand up from the chair. Try to imagine if you try to stand up, what force, which muscle you push, like would generate force to stand up. It's your thigh. So this explains perfectly why the patient is having such symptoms. And it also apply on other daily activities. So you can try to figure out for yourself, but just remember, if you can remember this proximal muscle weakness, there's no problem for you to understand the symptoms. And then ultimately, the respiration muscle will cause respiratory failure. And this is a very, very important fatal emergency. So once you identify there's a respiratory failure, just put the patient in a ventilator. And then after you figure out this MG, and you can continue on the treatment, which I will talk about later in the later slide. And before I talk about other stuff, I have to explain the mechanism of this disease. Some may find it difficult, but you just need a graph for you to understand. So a neuromuscular junction. So as a name, neuromuscular, neuro means we have a nerve cell here, and muscular, we have a muscle cell here. Junction means the gap here, neuromuscular junction. So there's a problem happening here. Normally, the nerve cell will produce acetylcholine and release this acetylcholine, these small dots, through the junction to bind to the ACH receptors on the muscle cell. But what happened in MG is there's some antibodies So there's some antibodies binds to the receptors on the muscle cell. Imagine it's like a musical chair. A group of people try to fight to sit on that single chair, and this is what happened here. Acetylcholine and the antibodies all try to sit on the chair, which is the receptor, but ultimately the antibodies got more chair, and which disturbing the signal transduction, so it causes reduced muscle contraction because acetylcholine is not able to get the chair to bind to the receptors. So it reduces the binding that leads to muscle weakness. And what's going to exacerbate the MG here is going to be infection or some stress, like physiological stress, not mentally, but like physiological stress like surgery, anesthesia, and also pregnancy or premenstrual state, and a bunch of medication. I found it difficult how to memorize the medication first, but you can try to combine some of them to understand, like the amyloglycoside I mentioned in the previous video. And one of the side effects of this is neuromuscular bondage. So as I explain the mechanism of this disease in this slide, as soon as you understand or remember one of the side effects of aminoglycoside is neuromuscular blockage, of course it's gonna trigger MG. They're literally similar mechanism. So I just not gonna write my poor handwriting. So once you understand it, you don't even have to memorize. This is how you learn it from it. And you will find a way. Anyway, there's a bunch of medication, the exacerbation factors, and also contrast media. So the myasthenia gravis (MG) is quite relying on your observations and physical examination. So I spend more time to talk about this part. But in the big picture, you see an ocular weakness, which is typically asymmetrical, and this is usually the first part to be affected, and the patient will find it and then go to the hospital. And the second is limb weakness, and which is typically symmetrical. And I already talked about the symptom of it in the previous slide, so I'm not going to go through it again. And that's going to be a normal deep tendon reflex. So as the ocular weakness is usually the first symptoms to be observed, we have a bunch of tests and signs to help the diagnosis. It is quite difficult if you just look at the definition, so I prepared a series of pictures to help you to understand. So the first one, but just go over it one by one first. The first one is Cogan lead treated sign. I called it coconut tree sign. I find it funny and it helps you to memorize. You can use it if you find this one useful too. Anyway, you ask the patient to look downward for 10 to 20 seconds and look forward. The affected side eyelid retracts while looking straight. And the second is curtain sign. You, the physician, hold up the eyelid of the most toxic or affected eye, and the ptosis will be worsening on the contralateral eyelid. The third one is ice pack sign. You apply ice pack on the affected eye for 5 minutes, and it improves the ptosis for at least more than 2 millimeters. And the last one is the Simpson test. Simpson, the cartoon. So this is also one of the way you help you to memorize the test. You ask the patient to look upward and at least more than 1 minute without lifting the head, without lifting the head to provoke an eyelid fatigue. So I have an image here, but I didn't mark them, so I hope you can try to figure it out by yourself. You can just look at this slide and then look at this, try to figure it out. But I will talk about that anyway. So we start with this image. This patient is looking upward. After upward gaze, we find this left ptosis after an upward gaze. So does it help you to remember anything? It is Simpson test. When ask the patient to look upward without lifting the head and provoke eyelid fatigue. So this action, looking upward, provoke the left eyelid weakness. Quite easy to understand, right? So we move to the second picture. We have the patient here looking downward, and then after that, the patient looking straight back again. We can see from here. But what happened here? We have a ptosis on the left ptosis, and with eyelid fatigue, and then it's getting worse and getting worse here. So what is this? It is our coconut sign. Coconut tree sign. Coconut tree sign. Anyway, the patient asked the patient to look downward for 10 to 20 seconds and then look forward, and the affected sides eyelid retreat while looking straight. Although I have an image here, but I strongly recommend you to find a YouTube video. That one is more clear, because it's a tracing, right? So a picture cannot represent it perfectly. So we better find any video, and there's a lot of them on YouTube. So move on to the third one. We have patient here. Before asking or doing anything on this patient, you can see already the right eye. There's a right ptosis here. You can see a weakness here. So in the next image, someone lift the eyelid up, of the affected side up, and then which ultimately causing the contralateral eyelid fatigue or ptosis. You can see here, it's kind of like normal, but then becoming like this. This is curtain sign. The ptosis will be worsening on the contralateral eye while you're holding up the eyelid of the most affected eyes. Exactly what happened here. And the last image, I don't think I have to go back to the slides because there's obviously an ice pack here. So it is a ice pack test or sign. So other than the eyelid fatigue, but some patients ultimately will find this weakness of the orbicularis oculi muscle. And what are this muscle? This long name. It's a bunch of muscle here, which kind of responsible for the motion of your eyelid. And other one of the characteristic or some of MG is this weakness on this muscle of the levator pulmonary superioris muscle. So this is why this weakness on this muscle causing the eyelid weakness, and then the weakness of the orbicularis oculi muscle will cause a partial opening of the palpebral fissures, which is here. So what happened here? Because this muscle is responsible for you to close the eyelid, you just ask the patient to shut the eyes, like using force, close your eyes hard, and then because there's weakness of this muscle, it cannot hold it for long. So eventually, it will cause a peak sign, like the eyes is not closed completely, like peaking. My poor drawing anyway, like peaking. So it indicates a weakness of this muscle. So how to diagnose it? We have a bunch of tests. One of it is an injection of 1 to 2 milligrams of aphrodonium chloride. And how does it work? It's gonna improve the symptom of ptosis. So if it doesn't improve, you can try and inject another 1 to 2 milligrams and then a 5 milligram bolus. But what is how does it work? How does it improve? As you remember the mechanism in the graph, I talked about it. So this one is an anticholinesterase agent. You can understand what it is from its name. Anti mean against. colon, you can think of about acetylcholine. Esterase, it means there's some esterase. It means gonna break something down. So this agent is something something that's gonna break down acetylcholine. So I mentioned, so there's this medication helps to fight for the agent, for the substance that gonna battle or exterminate or gonna kill acetylcholine, right? So when this agent help acetylcholine to fight for its enemy, a predator, it's gonna increase the population of the acetylcholine, right? So the acetylcholine is gonna have more and more numbers of acetylcholine, increase the populations, and with more manpower, it can outnumber the antibodies and get more share, which is the receptor, right? And this is how how androphonia works. So I hope I didn't make it complicated, but this is how it works. And since this is an anticoagulant and esterase agent, so always prepare atropine in case there's bradycardia or syndrome. And the second one is sleeping test. This is much safer test. You ask the patient to close the eyes for 30 seconds to observe any improvements. If you still remember, mentioned this, one of the most important characteristics of MG is the muscle weakness improve after rest. So you literally just ask the patient to rest for 30 minutes, and that's it. And other tests you can order is a serum assay. You're gonna find acetylcholine receptor antibodies, but some patients you cannot find it in the serum, so you can try to find there's any antibodies to muscle specific tyrosine kinase. And the second one is EMG, or the third one is chest CT. Why chest CT? Because one of the most important points is MG is commonly associated with pneumonia. So you have to order a chest CT to confirm it. So for the treatment, it's an anticholinesterase inhibitor, the same group of medication for the test, but instead there's different drug choice. And I hope you can understand my explanation of how it works. But anyway, they are all the same family for the diagnostic test and for the treatment. And the second one is immunosuppression, because this disease is by the attacking of the antibodies, right? So immunosuppressions can help. You may give glucocorticoid or others. And the third one is phlebotomy. If you find there's any phleboma, just contact the surgery department to remove it as soon as possible. It's gonna help for the treatment. So one of the emergency is myasthenia crisis. Is this acute life-threatening exacerbations of the symptoms ultimately leading to respiratory failure? So it's gonna happen within. It may happen within 1 to 3 years of the disease onset, and within 10 to 20% of the population of the patient. So all the exaggerating factor also apply on this crisis, and might due to overdose of the treatment of the medication we use for the treatment, but this is very rare. So when you find this respiratory failure, you put the patient on ventilation. It's like the protocol for the emergency, and then you identify this is a myasthenic crisis, so you give high dose prednisolone or even IVIG or plasma exchange. If you learn about AMG, you cannot skip Lamber Eaton Syndrome. They are like brothers. They are similar, but once you understand it, they are not. There are many differences. Like So, like I mentioned again and again, the characteristic of MG is the muscle weakness improves at rest and it worsens with exercise. But in Lamber Eaton Syndrome, LES, it's gonna be muscle weakness improved by exercise and worsen at rest is reversed. And then the MG is usually start with ocular weakness, and the LES is start with peripheral weakness. And MG is associated with thymoma, but this one is associated with SCLC, small cell lung cancer, and there's going to be normal reflex. And in LES, there's reduced or absent reflex. In the MG, there's normal autonomic functions, but in LES, there's going to be dysfunction. And lastly, the treatment. The MG is relieved by anticholinesterase inhibitor, but there's no response for LES, cause the mechanism of this is very different. I'm gonna explain it in this slides. So this looks a similar graph to the slide I explained the pathophysiology of MG. But what happened in here is not happened on the muscle cell. It's happened on the nerve cell. So what happened is, and also an antibodies that binds to the voltage gate calcium channel, which normally this VGCC channel allows calcium to go into cell and then fuse with the vesicle here and go through a bunch of like a series of reaction, and this vesicle is gonna release the acetylcholine and bind to the receptor on the muscle cell. But since the antibodies disturb this receptor, this process is not gonna happen. So a big cross here. This process is not gonna happen. So we don't have enough acetylcholine to release to the junction and then bind to the muscle receptor, and this cause the muscle weakness. And this is why we have so much differences on between MG and LES. So why does the muscle weakness improve at rest and worsen with exercise in MG? Because in MG, it is something wrong with the receptor here, and this nerve cell is still normal, right? So if you're increasing excitation on this nerve cell by like doing more exercise, it's gonna cause fatigue, and this is causing muscle weakness. But in case of LES, if you try to increase increase daily exercise or anything, so this increase the excitations on the nerve cell. So even though this antibody try to disturb this process, but if you increase the excitations here, still some gonna break through, like this, like outnumber the antibodies here, and then able to release some acetylcholine to the junction and binds to the muscle cell. And this is why the muscle weakness in LES improve by exercise but worsen at rest. So I always say don't try to memorize every stuff, right? And I think you also heard it from time to time from your professors or teachers. And so why does autonomic dysfunction is not a feature in MG but LES? Why? So this is because the antibody that's impaired the transmission in MG are specific for receptors called nicotinic acetylcholine receptors that is off specific for the muscle cell. And then since there's something wrong on the muscle cell part, and the nerve cell part is kind of like intact, right? So you're not gonna see an autonomic dysfunction. But in LES, because there's something wrong on the nerve cell part here, the 3GCC channel here. This is the nerve cell part. So there's gonna be a autonomic dysfunction, and this is very easy to understand. For the treatment of LES, you treat the underlying malignancy, the small cell lung cancer, or you can prescribe a drug called amifampridine. And how does it work? It works by blocking the presynaptic here potassium channels, which prolongs the action potential, ultimately increase the potassium concentration here, and like increase the concentration, and so that can go on with a series of action here, and ultimately try to release more acetylcholine, and that improves the muscle weakness. And this is the end of my video. And as always, I'm using the YouTube function to prepare some quiz at the end, and I hope it helps. Thank you for your listening.